Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. In today's lecture, we shall discuss update on MASLD in 2026. We shall discuss the MASLD in terms of its pathophysiology, metabolic crosstalks, risk stratification, and severity of the disease. We shall discuss these aspects in the light of available latest knowledge and understanding. And we will try to understand how to best approach a patient with MASLD, keeping in view the risk factors, disease severity, and the future possible complications for that very patient. Bismillah ar-Rahman ar-Rahim. As mentioned in the intro, we shall discuss the updates on MASLD in today's lecture. We shall discuss the pathophysiology, metabolic crosstalk, risk stratification, and disease severity. Greetings to all my friends in the other cities of Pakistan and across the world from Peshawar. Let's define the problem. This is the worldometer regarding the life expectancy in the world from 1950 to 2025. In 1950, the life expectancy in the male was 44.5 years, as shown in the blue bars. That of females was 48.4 years, as shown by the orange bars, and the both sexes combined life expectancy was 46.4 years, as shown by the gray line. And now in 2025, this life expectancy, as shown by this worldometer, has increased. In male now this is 70.9 years as compared to the 44.5 years in 1950, while in the female it has increased to 76.2 years from the 48.4 years in that 1950, and the combined has increased from 46.4 years to 73.5 years. So the fact is that the life expectancy in the world has increased from 1950 to 2025 in both males, females, and combined. And this graphs by the European Commission the total causes of the death of the world. It is showing the red is the in 2015 and the blue is the expected mortality in 2030. And what we see here, that the lower respiratory infections, it will decrease. The mortality associated with this will decrease in 2030. Same will be the HIV and AIDS mortality will go down. The diarrheal diseases mortality will go down. These three, it shows that the mortality will go down because of the good control of the infections. And that has resulted in the increased life expectancy. The life expectancy has increased because of the good control of the infections from 1950 to 2025. But the bitter fact is that when we see the mortality associated with the cirrhosis of the liver, it is going to be high by 2030. The same, the liver cancer mortality is going to be high. And then the hypertensive heart diseases mortality is going to be high in 2030. The same is for ischemic heart disease, for the diabetes mellitus, and for the stroke. So the mortality associated with the metabolic dysfunction or metabolic diseases is going to be the to be increasing by 2030. So despite the life expectancy has increased, the mortality associated with the metabolic dysfunction is going to be high. And in this century, the main challenge for health and for the life expectancy is going to be the metabolic dysfunction. So the fatty liver disease has become one of the commonest chronic liver disease worldwide. We should be aware of this, and we should realize that now the number one or the most common cause of the liver, the chronic liver disease, is the fatty liver disease. The terminology recently changed from NAFLD, that was the non-alcoholic fatty liver disease, to MASLD, which is the metabolic dysfunction associated steatotic liver disease. Now we call NAFLD as MASLD. This change is important because it shifts the focus, our focus, from what the disease is not. Here we used to say what the disease is not to what the disease actually is. So in addition to, or irrespective that it was a stigma and all those things, the change has really changed our perception. Initially, we used to say the disease is not because of the alcohol, but now we say the disease is because of the metabolic dysfunction. The new nomenclature emphasizes the metabolic dysfunction, insulin resistance, obesity, diabetes, dyslipidemia. These are the central drivers of this whole process. So the metabolic dysfunction, insulin resistance, obesity, diabetes, and dyslipidemia, these are the central drivers. Globally, approximately 30% of the adults, they may have MASLD. And the data is very well suggestive of that almost 1/3 of the population of the world, they have got MASLD. In South Asia and Pakistan, prevalence is rapidly increasing due to urbanization. We see more urbanization in these parts of the world, sedentary lifestyle, dietary transition, obesity, and type 2 diabetes. These are the factors which is increasing the prevalence of MASLD. And as I said, in the whole world, the prevalence is rapidly increasing in South Asia and Pakistan because of these five main factors: urbanization, sedentary lifestyle, dietary transition, obesity, and type 2 diabetes. This slide is showing the trends in rising global MASLD and other metabolic diseases. And this is from 2000 to 2021. The type 2 diabetes prevalence is increasing, the obesity is increasing, the hypertension prevalence is increasing, the dyslipidemia is increasing, and as a whole, the MASLD cases are increasing. And in world, by the according to EG Journal, 1.27 billion people were affected by MASLD in 2021. MASLD is not merely a hepatology issue. It's a major public health challenge. It's a major public health challenge affecting endocrinology, cardiology, nephrology, internal medicine, and primary care. So in all areas, we see the MASLD The patient presenting with MASLD, they can present to endocrinologists, to cardiologists, to nephrologists, to internal medicine, and even in the primary care. We know this, the metabolic dysfunction associated steatotic liver disease means the adult diagnostic criteria is that in the presence of the fatty liver, when a patient is any one of these will make the patient, the fatty liver patient, as a MASLD patient. If the patient is overweight or obese, if there is dyslipidemia or dysglycemia or type 2 diabetes, if their plasma triglycerides is high, if HDL cholesterol is low or the blood pressure is high. We know that the body mass index more than 25 kg per that is more than 23 in people of Asian, or if their waist circumference is more than 94 centimeter in men and more than 80 centimeter in women. In Europe and in Southeast Asia, these figures are low as compared to that. It is 90 for male and 80 for female. So any one of these, if the body BMI is high, if the waist circumference is high, we will, and there is fatty liver, we'll say the patient has got MASLD. Or if the patient has got normal body weight, the normal BMI, waist circumference is okay. But if the patient has got pre-diabetic status, that is HbA1c is 5.7 to 6.4, we say the patient has MASLD. Or if the fasting blood sugar is between 100 and 125, we will say the patient has got MASLD. Or if the postprandial blood sugar is between 140 to 199, we will say the patient has got MASLD. Or if the patient is type 2 diabetes established, then again we will see the patient has got type 2 diabetes, or if the patient is on anti-diabetic drugs. So even a patient may be lean patient, but if diabetic or pre-diabetic and with fatty liver, we'll say the patient has got MASLD. If these patient has got fatty liver and patient has got no obesity and no diabetes, but if the plasma TG triglycerides they were more than 150, or if the patient is on lipid lowering drug, again this will make him a patient of MASLD. Or even in the absence of these three, if the HDL is less than 39 in men or 50 in women, or the patient is on lipid lowering drug, again the patient in the presence of fatty liver, any one of these will be MASLD. And if the patient has got fatty liver and no obesity, no diabetes, normal triglycerides, normal HDL cholesterol, but if the BP is more than 130 by 85 or the patient is taking treatment for hypertension, again this will make that patient a patient of MASLD. And remember, one risk factor is good than two risk factors, are the two associated condition, comorbidity condition. Increasing the number of comorbid conditions, severe is the disease of MASLD. So this is very basics, no rocket science here. So the MASLD has become a global epidemic. We know that. Nearly 1/3 of adults globally are affected, and prevalence is even higher in patients with obesity and diabetes. Among patients with type 2 diabetes, MASLD prevalence may exceed 60 to 70%. It means 6 to 7 people with type 2 diabetes, they will have the MASLD. Similarly, the burden is especially concerning because many patients remain asymptomatic until advanced fibrosis develops. So, in other words, patient with obesity, patient with type 2 diabetes, patient with dyslipidemia, and patient with hypertension, they are the good candidates that they will develop the hepatic fibrosis, cirrhosis, and will die because of the liver-related causes. So economic burdens is also massive. These patients, they go to nephrologists, cardiologists, endocrinologists, hepatologists, all those things, and multiple visits. And as the time goes on, more and more and more complications appear. Important histological features include steatosis, ballooning degeneration, labular inflammation, and fibrosis. So steatosis we see in all these patients. Then we see the ballooning degeneration, then labular inflammation, and of course the fibrosis. So these are the four important histological features of patients with MASLD on liver biopsy. So coming to the different aspects we are going to discuss, we will be discussing the updates on pathophysiology, updates on metabolic crosstalk, updates on risk stratification, and update on disease severity. So first we take the pathophysiology. The pathophysiology of the MASLD we can understand this in steps. The first is the initiating mechanism. So mechanisms which initiate the process. Then central role of insulin resistance. And then the multi-hit hypothesis in contrast to the previously understood and agreed upon the two-hit hypothesis, now this multi-hit hypothesis, and of course the fibrogenesis. So these are the four main steps in the pathophysiology of MASLD. Let's first take the first step, that is the initiating mechanisms. Their genetic predisposition, people with PNPLA3 and TM6SF2 and MBO87, especially PNPL3 who are lean patients, they have got genetic predisposition to develop the MASLD. Then comes the role of the environmental factors, of course, our diet, our lifestyle, as well as the uh, environmental different factors. And of course, the dietary contributions, they play a major role as initiating mechanisms. And of course, sedentary lifestyles. So these, the genetic predisposition, environmental factors, dietary contributions, sedentary lifestyle, they initiate the process. Then comes the central role of insulin resistance. These lead to the insulin resistance. And in the insulin resistance, we see there's increased adipose tissue lipolysis, and there's increased free fatty acid flux to the liver, and there's hyperinsulinemia and hepatic de novo lipogenesis. So these are the four main components which are leading to increased fat entry into the hepatocytes and decreased fat exit from the hepatocyte and TG saturation. And these leads to then increased lipotoxic intermediates, which includes ceramides, DAGs, and free cholesterol. So because of these four mechanisms increased, and this is because of the insulin resistance which has developed because of these initiating mechanisms. So there's increased adipose tissue lipolysis, increased free fatty acid flux to the liver, hyperinsulinemia, and hepatic de novo lipogenesis, internal lipid formation within the liver, and from outside there's increased entry and decreased exit. So the TG starts accumulating in the liver, then they get saturated, and then there is the lipotoxic intermediates, they increased in concentration, and these include ceramides, DAGs, free cholesterol, and they damage the liver. Then the initiating mechanisms which resulted in insulin resistance, and now there's the damage to the liver, and this is the multi-hit hypothesis. There's the lipotoxicity, the toxicity associated with the lipid accumulation, then the oxidative stress, and of course the endoplasmic reticulum stress, and the mitochondrial dysfunction, and the inflammatory signaling. All these lead to the liver injury at different sites and in different ways, and of course hepatocytes injury. So these are the multi-hit hypotheses, different ways how the liver cells becomes injured and inflamed. And the chronic inflammation, we know it leads to fibrosis. So the fibrogenesis process starts, and this is the hepatic stellate cell activation, and they transform into collagen producing myofibroblasts. So there's major fibrogenic mediators include TGF beta, PDGF, and CTGF. And of course, the extracellular matrix deposition. So all these leads to fibrogenesis, and progression of fibrosis is then from F0 to F1, F2, F3, F4, and which result in cirrhosis. So this is a brief overview and latest understanding of ours regarding the pathophysiology of MASLD. Now the second component, that is the metabolic crosstalk. The liver has got the central role, and it metabolically talks with the cardiovascular system, extrahepatic malignancies, intestinal diseases, sarcopenias, pulmonary psoriasis, polycystic ovarian disease. We see all these associated with MASLD, the chronic kidney disease, hypothyroidism, diabetes. So all these conditions are related with the MASLD. It means there's a metabolic crosstalk in the MASLD. And we can understand these. The significant crosstalks are between the adipose tissue and liver. Then there's a gut-liver axis, the liver-muscle axis, the liver-pancreas axis, and the liver-heart axis, and the liver-kidney axis. So all these axes are present and they talk to one another. So what about the liver adipose tissue axis? The adipose tissue behaves as an endocrine organ. We know that it's the big endocrine organ in the body. So in obesity, the adipose inflammation develops. The whole adipose tissue gets inflamed. There's macrophage infiltration and which increases, and there's cytokine release which also increases. So the adipokine imbalance occurs. It means the leptin is increased, resistin is increased, and adiponectin is decreased. Adiponectin, when it decreases in normal way, this is a protective mechanism. So when it decreases, and when the adiponectin in normal condition, it improves insulin sensitivity and reduces inflammation. So when it is lower down because of the inflammation, there is low adiponectin strongly, and this strongly correlates with the fibrosis progression. So the protective means are gone and aggressive means come. Then the gut-liver axis. The gut and liver are anatomically connected through portal circulation. We know that the gut dysbiosis contributes to MASLD through increased intestinal permeability, endotoxin translocation, altered bile acid signaling, and microbial metabolic imbalance. So all these lead to the MASLD development. The lipopolysaccharide activates TLR4 signaling in Kupffer cells, and this amplifies inflammation and fibrogenesis. This gut-liver axis explains growing interest we know in the probiotics, prebiotics, and microbiome targeted therapies. Now, this is because of the gut-liver axis. Then the liver-muscle axis. The skeletal muscle dysfunction and sarcopenia happens here, and this worsens the insulin resistance. Then the liver-pancreas axis. The pancreatic beta cells, they become dysfunctional, and it accelerates progression towards diabetes. Then the liver-heart axis. Cardiovascular disease is the leading cause of death. We know in these patients, the patients develop endothelial dysfunction, atherogenic dyslipidemia, and accelerated atherosclerosis. And then the liver-kidney axis. The kidney disease shares inflammatory and fibrotic pathways with MASLD, and they both become fibrotic and lose their function with the passage of time. Thus, MASLD should be viewed as a multi-system metabolic network disorder. Now, let's see the briefly updates on the risk stratification. What do we now understand in 2026 about the risk stratification of these patients, and why this risk stratification matters? It is essential. The risk stratification is essential because most patients with MASLD will not develop advanced liver disease. We know that. But a subset will progress rapidly. So to identify advanced fibrosis, to predict liver-related outcomes, And to predict cardiovascular mortality, we need to have the risk stratification of these patients. So there should be a stepwise approach. How to do this risk stratification. Step 1, the clinical assessment. That's very, very important. Step 2, laboratory assessment of these patients. Step 3, non-invasive fibrosis scores. Step 4, imaging based assessment. And step 5, the liver biopsy. So we do the risk stratification in these steps. So the first step, that is the clinical assessment. Of course, if the patient has got obesity, patient is type 2 diabetic, or the patient has got metabolic syndrome, or there is a family history of MASLD or alcohol intake, these are the risks that the patient disease will behave worsely. Similarly, the lab assessments, the ALT-AST ratio, the platelets counts, the albumin, the HbA1c, and the lipid profile, these are the parameters which tells us that whether the patient is at the risk of worsening of disease with the passage of time or not. Then few non-invasive fibrosis scores which are very, very important and in fashion nowadays in managing these patients. One is FIB4, another is NAFLD fibrosis score, then the EPRI, and of course the ELF score. These are very, very important regarding the liver fibrosis or the risk stratification of these patients. Then imaging based assessment. And in these, ultrasound is the really the most common one, most commonly used, then the CAP, and then the fibroscan, and of course the MR elastography. These are the tests which give us the risk stratification of these patients, and of course the liver biopsy. And we know we should be clear about the indication, why we want to do, what advantage we can have, and what are the limitations of liver biopsy in our clinical practice. So after understanding the pathophysiology, the metabolic crosstalks, and risk stratification, let's have the updates on the disease severity or understanding. We know certain patients are at particularly high risk of for progression. The important predictors include advanced fibrosis. Those patients who have got advanced fibrosis is determined either by the fibroscan or non-invasive calculators or even biopsy. Then if the patient has got diabetes, patient is obese, patient is sarcopenia, and patient has got persistent inflammation, or patient is elderly, or if there is genetic susceptibility, these are the patients who will develop severe disease. So the patients with type 2 diabetes have significantly higher risk of fibrosis, cirrhosis, HCC, and cardiovascular mortality. This is a known fact. So MASLD or fatty liver with diabetes and without diabetes, they behave very differently. MASLD leads to both hepatic and extrahepatic complications. And the hepatic outcomes are the patient, they develop cirrhosis, portal hypertension, liver failure, hepatocellular carcinoma. And the extrahepatic outcomes is that they develop cardiovascular disease, chronic kidney disease, they develop stroke, and malignancy. These are the direct manifestations of MASLD. So, understanding all these, and why we should be understanding these, because this is very important that we should think about the therapeutic implications. The first therapeutic implication is, of course, the lifestyle intervention, then is the metabolic targeting, then emerging pharmacotherapies, we should be knowing that as well, and the future directions. The lifestyle intervention, we know it remains the foundational intervention. The weight reduction, the exercise, and the diet, especially the Mediterranean diet. And our aim is to lose the 7 to 10% body weight and within next 6 months. And this may significantly improve MASH and fibrosis. Then metabolic targeting, the diabetes control, lipid management, obesity therapy. These are very important that we should be targeting the associated comorbid conditions. The emerging pharmacotherapies, we know GLP-1 receptor agonists are there. The dual and triple incretin agonists have been poured into the market. Then the thyroid hormone receptor beta agonist, the resmetirom, then the insulin sensitizers. These drugs are now with us for treating these patients, and the future is that of anti-fibrotic agents. The future direction, I think, it lies in the precision medicine, the personalized medicine, and the microbiome therapy and the combination therapy. So this is going to be the future treatment options for these patients. So this is just a slide, and the MASLD, and this the word MASLD has meaning of the whole story here. The M means metabolic dysfunction, means obesity, which leads to insulin resistance and which leads to the type 2 diabetes, hypertension, and dyslipidemia. So the M stands for the metabolic dysfunction, meaning all these things. Then A means for adipose and inflammatory signals, which includes there is TNF alpha increased, IL-6 increased, IL-1 beta increased, and this leads to adipokine imbalance and oxidative stress. Then comes the S, steatosis and fibrosis, in the same sequence. There's a metabolic dysfunction, then there are the signals, and this leads to steatosis and fibrosis. Hepatic fat accumulation is there. We see the mitochondrial dysfunction, and then the fibrosis is a key prognostic factor. Then is L. L means for leaky gut and microbiota. So the gut dysbiosis, increased lipopolysaccharides, TMAO, which leads to liver and vascular inflammation. And then there's the D, disease progression and cardiovascular risks, so atherosclerosis and atrial fibrillation, hepatic function with preserved failure with preserved ejection fraction and increased cardiovascular mortality, and later on liver related mortality. So even the word MASLD, it encompasses the whole story. So the key takeaways from today's discussion is MASLD is a systemic metabolic inflammatory disease. The insulin resistance is the central driver. The multiple organ systems interact through metabolic crosstalk. The fibrosis stage is the strongest prognostic marker. And cardiovascular disease is the leading cause of death in the early stages, and early risk stratification is essential for these patients. And multidisciplinary management is required. So the final words, my dear colleagues, is the liver in MASLD is both a victim and an amplifier of systemic metabolic dysfunction. I repeat, the liver in MASLD is both a victim and an amplifier of systemic metabolic dysfunction. Understanding this metabolic crosstalk helps us move from treating fatty liver alone to treating the entire metabolic disease process. Thank you very much for being with me. Please do share your comments, your thoughts, your experiences in the comment section below. And if there are any query, please do ask that in the comment section, and I will try to answer that. Thank you very much. See you in the next lecture on some other topic. Till then, take care. Khuda Hafiz.